Welcome to MD Insights. I'm Matt Walsh of the Digestive Disease and Surgery Institute, and it's really a pleasure to have today Dr. Ali Mallat, who's an acute care and trauma surgeon. Welcome, Ali. Tell us a little bit about your specialty and how it's come to develop over the last couple decades.
So, acute care surgery now involves three services, mainly trauma surgery, emergency general surgery, and surgical intensive care unit. The service started as trauma service back in the days where there was a lot of need for trauma surgeons. And then the trauma surgeons were taking care of a lot of sick patients, and this is where the need to have a surgical intensive care unit and surgical critical care board. So that was added, and most of trauma surgeons by nature are general surgeons. So we do a lot of general surgery, and because we're on call for trauma, we found it easier to also tack on the general surgery on top of the trauma call. And with time and with the years, actually that service has developed quite a lot, where we have shown that there is an improved outcome when there is a dedicated surgeon on call available 24/7. And when we actually put all these type of patients on the same service, it just makes everything better streamlined. Patients are better cared for, and the surgeon is available 24/7. When patients were cared for by the elective surgeon who do a good job in their services, it's the availability of the surgeon who has clinic, who has a schedule for the morning that he has to attend for, and then they take the night call. So the efficiency was not there. Cases were getting delayed. And when we created the acute care surgery, dedicated operating room for the emergency surgery, things really picked up and were done in a much better way. Hospital length of stay went down. Patient outcome has improved.
So in terms of emergency general surgery, what are some of the typical problems that you would deal with?
Well, the typical problems are usually gallbladder disease, hernias, incarcerated type of hernias, appendicitis, perforated bowel, diverticulitis, even pancreatitis when they're sick or surgical, perforated ulcer, stomach ulcer, or duodenal ulcer. Pretty much any emergent surgical disease. We even take care of like emergent cancer surgeries where there is a perforation or a bad infection associated with it. Other type of surgery that we do is for bad infection, like a gangrene type of infection. These type of surgery we also do.
So these types of problems are still going on. Does any change over time in sort of the incidence of these relative problems?
Yeah, unfortunately, the incidence of these have not gone down. It's just the care that has improved for these patients. The patient length of stay has improved, and the patient outcome has improved with such type of service, having a dedicated emergency surgery service. But we have more and more patients. Unfortunately, with COVID recently, our incidence or our number of cases done emergently have increased, and that's because many of the elective procedures were delayed, and it wasn't, except for the very important type of surgery that were allowed to be going. We were busier and busier.
So we might as well talk a bit about the pandemic and the need for emergency surgery. Are the complications after surgery increased if you have COVID?
So yeah, after surgery, there are complications that have increased, and until now, and the majority of those complications are related to blood clots. and pneumonia or ARDS risks have increased with COVID, unfortunately. If a patient has a, not I would say semi-need to have surgery, sometime we would treat, and they are COVID positive, we would treat them symptomatically and ask them to come back in 4 or 6 weeks, depending on how severe the COVID disease is. We would ask patient to come back. There is 4, 6, there is even 8 weeks if they had severe infection. If they went to the ICU, most of the time we wait longer than 2 months.
And the blood clot problem that you're describing in COVID patients, is that different than the blood clot problems with the vaccine that we're hearing about now?
So, the mechanism is probably very close. We can't tell for sure. It is similar, but it is a very close mechanism. The blood clots can occur with COVID or with the vaccine. They can occur anywhere in the body. They don't have to be, lower extremity DVTs, the one that they occur usually after the surgery. They can be, pulmonary embolism or even a stroke. There's similar mechanism. We're not 100% sure the exact mechanism, though.
Okay. So I did want to talk a bit about some of the techniques of surgery for emergency general surgery cases. When you were originally a trauma surgeon, I assume everything was done with open surgery. How has been the adoption of laparoscopy and robotics been in emergency general surgery?
Yeah, so as a trauma surgeon, as you alluded to, we don't do many minimally invasive surgery because patients are sick and they need surgery right away. They need bigger type of exposure. They may not have one type of injury and they may have multiple problems in the abdomen, which would be very hard to do laparoscopically. For the stable trauma patient, we used to do laparoscopy, and we still do laparoscopy for the stable trauma patient. Having said that, for emergency general surgery, we do laparoscopy all the time, and because we're usually dealing with one simple problem. The problem with emergency cases is some patients are they had morbid disease from the beginning. They have lung problem, they have cardiac issues, they are having also renal failure sometimes, they're morbidly obese. And doing surgery with laparoscopy has a limitation of a 2-dimensional picture that you're looking at, a one stick straight stick that you use to reach the area. And if you don't have a good exposure, a good manipulation, or an angled view, it becomes hard to continue the procedure. For an example, a gallbladder. A gallbladder can be very inflamed, very friable, deep into the liver, and at the same time, patient can be morbidly obese. If you do it laparoscopically, most of the time, the success is there. So it's not like it's a bad plan. It's actually a great plan to do it laparoscopically. Having said that, there is a chance that you may have to convert to what we call an open procedure. And that would involve cutting through the muscle of the abdomen. On a healthy patient, if you do that, or you had to do it, it is okay. But on a morbid patient and morbidly obese patient, it becomes a major disability after the surgery. They have to stay longer in the hospital, and they may have to go to the intensive care unit simply because of a pulmonary decompensation after the surgery. This is where the robotic part comes in. And with the robot, not only the view is better, it's the 3-dimensional view, but also the dexterity of your hand is there and it's transmitted through the robot. You can reach into places, you can hold things a different way. And that has, I can say to me, that has almost abolished the chances of having to open a patient. Unfortunately, the robot is a finite resource and require a dedicated team. And because of its general emergency surgery, the robot may not be available at all times. Obviously, the more you use the robot, the more you sharpen your skills and you learn how to use it in better ways. But it's a finite resource, and it's more expensive. Yes, the surgery is a little bit more expensive than laparoscopy, but the overall patient care and outcome actually makes that less expensive than having to open a patient.
So we're talking primarily about gallbladder surgery right now. Is that where you see the best use of the robotic platform?
Yeah, it is. So far, it is the best use for the robotic in emergency surgery. Obviously, in elective, that's a totally different type of surgery. But in emergency surgery, the gallbladder disease and cholecystectomies have proven to be the most efficient one from a cost standpoint and from an outcome standpoint, length of stay and whatnot. It can be used in appendix, but it may be a little bit overkill for the time being. I'm sure with time and cost cutting and more efficiency and less time to dock, you'll be able to do a better job with appendectomy. But right now, it's not the skill; it's more of the cost and the dedicated team availability and whatnot that limits us. For colon surgery, it is actually a very useful one, especially if we have the newer versions of the robot, like the XI compared to NSI, if we're talking about versions. For colon, then it would be good, especially for diverticulitis, including diversions and whatnot, or resections.
So just talking about it for colorectal surgery, would that somehow increase the likelihood of not needing a stoma in the surgeries you're doing if you do it robotically, or is that not part of the equation?
I don't think this is part of the equation, because the decision about making a stoma or not is based on, the classification of the spillage, of how inflamed the tissue is how sick the patient is. You actually may not have enough time to do laparoscopy or robotic surgery for such patient, because sometimes they're very sick and you just need to get in and out fast, treat the patient, and keep them alive until you can fix the whole problem at a later time. There are very selective indication for robot in these cases, and I'm sure with time things will change, but for the time being, would be very selective with it.
So let's go back to the gallbladder. The typical patient with an infected gallbladder, acute cholecystitis, we call it, do having these different instruments or approaches, laparoscopy and robotics, change the timing to operation?
Timing to operation if you have a dedicated emergency surgery team, there is no difference in time for us, because we have a dedicated room, and then the robot is either available or not available. So it wouldn't change the time. But it would change the time off the operation, not to the operation. Docking the robot takes a little longer time, although some people have perfected it down to 4 to 5 minutes. I can tell you it still takes me about 10 minutes to dock the robot. So that is an added time. Now, depending on how difficult or how severely inflamed the gallbladder, sometimes it's actually faster once you dock to do it robotically than have to do it laparoscopically, because the exposure is easier and better.
So is the paradigm, though, that you would still start virtually every case laparoscopically and then convert to robotics instead of converting to open, or are you starting some straight away with robotics? How do you decide?
We decide, currently we decide based on availability. If I had the option of starting the cases, all emergent cases, I would actually start them robotically, except if I have like a thin patient that does not have medical problems, or the gallbladder, I'm not expecting to see a very inflamed gallbladder. For the semi-elective type, I would just do laparoscopy. It's shorter time, it's much more efficient. There's really no need for robot. But for the morbidly obese patient, the patient that have medical problems that are unsettled, or that I'm concerned about their post-operative care, those are the ones that I would right away start with robot. I rarely convert from laparoscopy into robot, and this is where it becomes an issue. You have to start in a room where the robot is already set up. So you either start laparoscopy, convert to open, or robotic, convert to open. We haven't had that yet, but you might one day.
And if you did robotic cases at midnight, would that increase your availability of the robot?
Oh yeah, absolutely. It's just that the team education, the staff. Yeah, if that, I would do it at midnight. I would do it anytime. We work 24/7.
So talking about the team, does it take a dedicated support team to do the robotic cases?
So it does. It takes a little bit of an education. We're lucky to have a residency program in our institution. So the residents obviate a lot of the need for dedicated team because we help each other and we get it done. You still need to have knowledgeable nursing staff, scrub tech, and nurse in the room to get items and material from the outside the operating room. You still need that. So if you have someone else covering in the middle of the night and they haven't done robot, although they can all be educated, and there are studies of how fast they were able to educate a full operating room, how efficient that was, but it still is it has its own limitations.
So what about assessing the biliary tract during cholecystectomy if you're using the robot? What options do you have?
Yeah, I'm glad you asked that. So this is another one that you can use the robot, and although it exists in laparoscopy, but not many of the laparoscopic tower have it, but you can actually inject IC green prior to the surgery, right before the surgery. And with the robot, you can see actually the biliary tree, the whole thing, and that limits, we believe it decreases the chances of injuring the bile duct. It helps us with dissecting the gallbladder much faster and easier because you know what you're cutting or what you're dissecting, what you're pulling at, compared to being blind, I would call it nowadays.
And since you find that the robotics work particularly well in heavier patients, is using ICG the same? Is the visualization as good in a heavy patient compared to a thinner patient?
No, it is not. And we have tried increasing the dose. It might help. It doesn't help really well. Visualization goes down because there is another layer of fatty tissue over the bile duct or the liver hilum. So it's not the same. It still is very helpful. It still helps with anatomy. It is not the same.
And any other novel procedures with robotics? How about perforated ulcer disease? Have you used it in that situation?
Yeah, perforated ulcer disease, we currently do it mostly laparoscopic because we've been very efficient with it. I believe that at times when the ulcer has been difficult, like larger ulcer, not a straight type of ulcer, or the angulation is not really easy, I have wished many times like I should have docked the robot. The fact that the majority of them, when patients are stable, and you do it laparoscopically, that you can complete the procedure laparoscopically, it's so far we haven't moved for robot from the beginning like we have done with gallbladders, but I can see that of a significant use.
So if a surgeon is talented, let's say laparoscopically, how difficult is it to learn robotic techniques, do you think, for emergency general surgery?
It is not difficult at all. I mean, I was doing everything laparoscopically, and I learned the robot, took dedicated courses, got mentored, and then it's actually, I would say I would relate it more to your skills as an open than laparoscopic, if anything. The open technique and robotic technique are very close because of the manual dexterity of your hand when you're using the robot. The laparoscopy require different type of technique, if anything. So if you're good laparoscopically or good surgically, I think you'll pick up the robot very easy.
And are there any cases now that you think should just start open?
Aside from, open. If
open.
Anytime, yeah.
Remember that? Kid.
Yeah. Yeah, that depends on the patient mainly. And if the patient is in extreme, I would certainly discourage any surgeon to use a robot or use laparoscopy for that matter, because you need to be faster. Sometimes you need to be more efficient with space, I would call it, not efficient as an overall, but also with space inside the abdomen, and having an open, wider exposure when you have a sick patient is very important. Obviously, unstable patients should always be an open technique.
So, technological future advancements you're looking at in the horizon for emergency general surgery?
Well, the more we can miniaturize the robotic arms and camera, the better. Docking, it has gone significantly better, but it still is, more times. Other things are for the robot. There are ways you can test and measure efficiency of a surgeon, trainee, ways to train in a better way. There is also new AI software that can be embedded in robot where it can help, at least delineate where the structure would be based on other patients. Those are very helpful during the surgeries. Same way you're helped with the IC green to see, the green color where the bile duct is. There are ways where a software can tell you, okay, the iliac artery is here, or the ureter should be passing by this area, although we can see it with the IC green. But those can be also delineated using software.
Well, thanks for this update, Dr. Mallat. It's very nice to have you on MD Insights today.